Hi, my name's Stephanie and I'm going to talk about preterm labor. Here are my topics for this presentation: goals for the patient, risk factors, patient education, treatment, impact on the next stages, psychological and social impact. So what is preterm labor? Preterm labor is when a woman goes into labor before 37 weeks and has cervical changes, uterine contractions, or a rupture of membranes. Our goals for a preterm labor patient is to have them verbalize understanding and outcomes, report anxiety, appearing relaxed, engage in appropriate activities such as walking or using the peanut ball. Patient is able to verbalize reduction of contractions, decrease in frequency, time, and strength, as well as visualizing a decrease of contractions on the monitor. We want to prevent injury of the mom in cases such as placenta previa or lowering infection risk if rupture of membranes has happened. The goal is to have a healthy baby. The best way to do this is to maintain the pregnancy as long as the mom and the baby can tolerate it. Some risk factors for a preterm labor are if you've had a previous premature labor, you are pregnant with multiples, uterine or cervical anomalies, for example, placenta previa or bicornucate uterus, preterm premature rupture of membranes, being under or overweight, family history of premature births, becoming pregnant too soon after a previous birth, having pre-existing health conditions such as high blood pressure and diabetes, smoking, drinking, alcohol abuse and drug use, domestic violence, stressful work environment, exposure to chemicals, and being older than 35. We want to educate the patient on signs and symptoms they would be looking for, such as 4 or more uterine contractions in 1 hour, vaginal bleeding, increased pelvic pressure, abdominal cramping or low back pain, changes in vaginal discharge, and preterm premature rupture of membranes. Preterm labor can be diagnosed by testing for amniotic fluid and cervical changes. Some complications of preterm labor could be a delay in infant development, health, complications depending on estimated gestational age, fetal death, and/or maternal death. Since the patient is concerned about preterm labor due to the signs, we would like them to reduce the risk by reducing stress, preventing infection, treating chronic health conditions, and advising not to smoke, drink, or use drugs. These are some resources I found that would be good for patients to help them understand what they are going through. One of these is a pregnancy support group discussion that allows for women to talk with others that are going through or have gone through similar journeys. Treatment. The nurse would follow the doctor's orders of placing patient on bed rest, monitoring contractions and fetal heart rate, administering tocolytic medications as well as betamethasone and IV fluids as ordered. Actually, did you know that if a pregnant mom is dehydrated, it will cause her uterus to contract? I think it's interesting that something as simple as giving fluids can help to rehydrate and relax the uterus. A nurse may also be assessing for cervical change if rupture of membranes has not happened, while also keeping the NICU and doctor in the loop of the mom's condition, and most importantly, supporting and reassuring the family throughout this process. The drugs I'm going to be talking about next are tocolytic drugs, including progesterone and magnesium sulfate to reduce contractions, as well as betamethasone, which is given to try and improve surfactant in the baby's lungs, helping them to be more stable at birth. Keep in mind that these drugs are not long-term. The goal is to stop preterm labor for as long as possible. Sometimes it works and sometimes it doesn't. These next few slides have all the information on these drugs with a full medication classification form. Magnesium sulfate is an unlabeled use med given as a treatment for preterm labor to slow or stop uterine contractions. Since this is a high alert med with multiple side effects, it only should be given under hospitalized care with careful monitoring of the mom and fetus by the nurse. Classification is mineral and electrolyte replacement or supplement. The action of this medication plays an important role in neurotransmission and muscular excitability. Administration considerations for this medication are that the antidote is calcium gluconate. This always needs to be available during administration. Due to this being a high alert med, it should not be given if respirations are less than 16, if knee reflex isn't present, and then ensure that there is a second person to double check the dose, the time, and the pump settings. The dose should never exceed 150 milligrams per ml, and the recommended loading dose is 4 grams IV and 100 mils IV fluid, infusing over 30 minutes. Some contraindications are not using the med for more than 5 to 7 days for preterm labor, which can increase the risk of hypocalcemia and bone changes in the newborn. We want to avoid active labor or giving the med with active labor or within 2 hours of delivery, because it could be a potential cause of magnesium toxicity in the newborn. Hypermagnesemia, hypocalcemia, heart block, and anuria. And then you don't want to use this med with nifedipine. Side effects are drowsiness, decreasing respiration rate, hypotension, diarrhea, muscle weakness, flushing, sweating, hypothermia, dizziness, nausea, nystagmus, headache, lethargy, and pulmonary edema. Nursing considerations are to do vitals, do a neurostatus, checking knee jerk before each dose, monitoring eyes and nose, ensuring the mom is peeing at least 100 mils per 4 hours, monitor newborn for respiratory depression, hypotension, hyporeflexia, continuous fetal monitoring as well during labor. Patient education is just that they know the different side effects of this medication. Progesterone is often used with women that have previously experienced a premature labor. Some women may need this treatment if they have a shortened cervical length as well. Progesterone is usually given to women with current symptoms and a previous preterm premature rupture of membranes. The trade names are crinone, endometrin, and prometrium. Oh, and then urogestrin. The medication class is a hormone or progestin that is given to manage infertility, support the embryo during pregnancy, and for corpus luteum dysfunction. Progesterone works by relaxing the uterine smooth muscle. The desired effect is to control uterine bleeding. Administration considerations for this med are 300 milligrams by mouth total in a day, having 1 dose after breakfast and 1 at bedtime. A 100 milligram vaginal insert is used 2 to 3 times per day with a disposable applicator. Usually contraindicated in pregnancy unless there is a corpus luteum dysfunction. Some side effects are pulmonary embolism, thromboembolism, hypersensitivity reactions, anaphylaxis and angioedema, depression, breast tenderness, spotting, edema, and gingival bleeding. Some nursing considerations are vitals, including blood pressure, eyes and nose, assess bleeding, and continue fetal monitoring. Some patient education are to report signs and symptoms of fluid retention, notifying the provider of vaginal changes or signs of labor, use sunscreen while taking this med. Betamethasone. It's used to induce or quicken the development of the lungs in the baby during tocolytic therapy. Surfactant therapy for the newborn is especially done between 24 and 34 weeks for at least 24 hours when women are undergoing tocolysis. This is an anti-inflammatory corticosteroid in its class. Indications are short-term administration to high-risk mothers before delivery to prevent respiratory distress syndrome in the newborn. Its action is to suppress inflammation and modification of the normal immune response. The desired effect is to prevent respiratory distress syndrome in the newborn. Administration is usually 12 milligrams per day, 2 to 3 days before delivery, IM. It's contraindicated with epidural use, hypersensitivity to bisulfites, safety not established in pregnancy. Side effects are depression, euphoria, hypertension, peptic ulceration, acne, decreased wound healing, ecchymosis, fragility, hirsutism, petechiae, adrenal suppression, thromboembolism, muscle wasting, osteoporosis, Cushingoid appearance. Some nursing considerations are to monitor serum electrolytes and glucose. May cause hyperglycemia, hypokalemia. Assess for hypotension, weight loss, weakness, nausea, vomiting, anorexia, lethargy, confusion, restlessness. You also want to be monitoring eyes and nose and assessing for signs of peripheral edema, including lung sounds, weight gain, dyspnea, shortness of breath. Patient education is to review side effects to alert primary care provider about. That it may mask the symptoms of an infection. Encourage the patient to eat a diet high in protein, calcium, and potassium, and low in sodium and carbohydrates. And then advise the patient to avoid alcohol during therapy. Impact on the next stages, labor. Women that are experiencing preterm labor will need increasing of teaching and anticipatory guidance. While all labors have a team present, preterm labors need extra attention from the NICU, RT, and possibly the OR if something were to go wrong and a C-section was indicated. Impact on next stages, growth and development, and future pregnancies. Depending on what stage the woman is at when she is going to give birth depends on which stage the child is at. The earlier a woman gives birth determines the development of the baby and the length of the hospital stay for the baby, which can have a really great impact on the parents. Having one preterm labor puts you at a risk for having future preterm labors, as well as the possibility of not being able to carry any more children in the future. Psychological or social impact. What is the patient and their family likely to feel during this time? Fear, worry, anxious, ineffective coping, pain. Due to the risk of the baby not being fully developed and possibly having some health issues from being born too early, the birthing mother or parents are likely to feel fearful of the unknown, worried about the outcome, anxious, have some difficulty coping, and have both emotional and physical pain. Allowing the patient to express their feelings and ask questions are two of the main ways a nurse can provide good patient care. It is also important to educate, provide resources, and different coping mechanisms. It is also the job of the nurse to provide anticipatory guidance of what to expect to the best of our abilities. This includes how to bond with the baby, such as skin to skin, if able to, or holding the baby, talking, touching through the isolette. All of the equipment needed to support their baby may be very intimidating for these parents. We should ensure they are prepared before entering the room and have everything they need to know. Here are my references. They are a great place to look for more information. Thank you for listening to my presentation. I hope this was educational and understanding about preterm labor.